am Chilmuru Dhanush, pursuing a bachelor's degree in Sri Ramachandra Institute of Higher Education and Research. Today I am here to talk about a topic, intrafusion MRI for enhanced neurovascular and viscerovascular imaging. So getting into the topic, at a very fundamental level, I would like to let you know what is an intrafusion MRI, what are the clinical advantages that we can achieve with this intrafusion MRI technique, and how to perform this post-processing on different workstations, and what are the scan parameters that you need to do a proper post-processing to avoid common mismatches and pitfalls. First of all, let me explain how this technique works. Usually when we talk about fusion, our mind goes like, we need to fuse an MR image with a PET CT or any other modality. But in this technique, the title itself says intrafusion MRI, means we are fusing the sequences together. So in between, so with the MRI sequence itself are being fused together. So to put it very simple way, you can see here an axial vibe is there next to a DW image. So your axial vibe has an anatomical detailing where your DW has an enhancement. So when you fuse them together, you are having an image where DWI plus vibe is there, where in a single image you are able to provide anatomical and pathological details together. So that's the whole concept is about. So now let me explain some clinical details about it. So it has a clinical role in ruling out neurovascular conflict, or in evaluating anal fistulas, and also for pre-operating assessment of corticospinal tract in regions. So here we have a case of neurovascular conflict. So I will explain how this fusion works in a simple way. So here we have trigeminal nerve, and now critically in a case of neurovascular technique, the radiologist wants to know the relation between the vasculature and the nerve. So is it overlapping or is there any compression to rule out that? So they will be parallelly watching this nerve and arterial relation. So here there is a nerve and here there is an artery. So when you run parallelly, you will get an idea between the relation. So when they have been fused together, here we can see the trigeminal nerve, and it might be a posterior inferior cerebral artery that has been overlapped. So the both anatomical details and been shown together, then you will get an idea between the relation between the nerve and an artery. So such reformats would be really appreciated when you do a proper fusion. So coming to the next case, so how to perform this post-processing if you are using Singo via operating platform. So once you have finished your image acquisition, you have a Fiesta and a T2 weighted image at off, then you need to fuse them together. Now how do you fuse this? You just drag and drop the image, then it shows an option called fuse. So if you once click on the fuse, it will fuse, and even after you have fused the image, there might be a slight mismatch, and this mismatch is very critical in order to show the relation between the nerve and an artery. So if the mismatch is not accurate, the radiologist couldn't comment about it in a proper way. So once you click on this automatic registration, then the mismatch would be perfect, and below that you will be having an option where you can adjust the ratio, which sequence you want to be dominant. So such proper reformats will be appreciated. And once you are done that, there is a significant part here. You need to add a color grading to your image, because without a color grading image, both of them will be appearing hyper intense and it will be difficult to differentiate. So on right side bottom, you will be having an option called window width adjustment, and there you have a color grading. You need to apply hot iron filter. And if you are using GE workstations of 1.5T or 3T MRI, now I will also show how to do that on these machines. So again, you need to load two sequences of T2 weighted image, or you can also run with a Fiesta. So drag and drop, and it asks, do you want to mix the views or reassign the views? So you need to click on the mix the views, and you will get an fused image. So like I have previously told that there is a significance of adjusting the contrast in certain way. So if you directly fuse the image, and if the image appears like this, the radiologist still can't differentiate the nerve-vascular relationships. So here we need to ramp down the threshold value of the window adjustment. So from this we will be getting an image that appears like this. In this situation, we can appreciate the trigeminal nerve and the arteries that are coming over that. So such window could be only optimal for diagnostic purposes. And once you have done with that, on right side top, you will be having this option where you can save your work. So coming to another clinical application for fusion MRI and tractography together were being fused for a corticospinal preoperative assessment in tumor patient. So usually when a patient is having a tumor or a glioblastoma such case, and it needs to be surgically operated, now so the surgeon needs a proper anatomical base before planning a surgery, because in a post-operative surgery a patient might lose his sensory motor functions. So for that surgeon needs to know which region he is going to touch. So for that we need to know where the corticospinal tract pathways are. At the same time, we need to know which region has which cortex. Is it a function, is it a speech cortex or is it a motor cortex? That's what primarily we need to be aware of. So for that we will be needing two things, DTI and a functional MRI and a anatomical base. When these three things being fused together, then we will get a proper idea for a surgical approach. Now let me explain how to do this post-processing. So here we need to take an DTI sequence and put it in ready view, and once you have loaded that, you will be having an option called fiber tracking, where you need to track the fiber corticospinal tracts. So you need to draw a proper ROI. This is a very crucial part. We need to draw a proper ROI which generates the seed. You need to draw proper ROI at the seed of the corticospinal tract. Only then you will get a complete view of your tract. So once you have drawn a proper elliptic ROI and click tract, then you can visualize the corticospinal tract. Okay, we have generated the cortical spinal tract over here, but still the image base is on a DW image. So we need an anatomical base which shows the relation to the cortical spinal tract with our brain anatomy. So we need a 3D sequence, preferably Bravo. Now we need to fuse this anatomical base with our cortical spinal tract. So you need to drag and drop, and once you did that, you will get an anatomical base with the cortical spinal tract which shows the relation, the mass effect and everything. And there is also another pattern that you can do if you do a T1 weighted post contrast sequence, and if you push that and if you fuse it together, then you can assess the relationship between the cortical spinal tract and the mass effect. You can also see how the mass effect has deviated the cortical spinal tract's pathway, and till as of now we have seen how the cortical spinal tract's pathway shows us, but the cortical spinal tract pathway shows only how to like what is the pathway of the spinal tract, but still we don't know which region provides what function. So that's where functional MRI roles comes at. So if you see when you run a functional MRI and patient is asked to do a certain functions, like moving his fingers or speech, then we will understand which region is specifically being activated, and we can label such regions. Okay, this region is responsible for speech, this region is being held responsible for motor movements. So then when we have the surgeon has an idea about his cortical spinal tract and his functional movements and anatomical base, then it will be useful for surgeon to plan a proper anatomical base. So that is its clinical application is about. And there is another small clinical application, MR fusion for evaluation of anal fistula. So in a regular anal fistula, some fistulas might be difficult to address. So here we have an axial T2 weighted image with a DW image. So when we have fused them together, you will have an image that has good anatomical details, and if you have color grading, it will be more informative. So we have some parameters that we need, like I previously told. We need to adjust a proper window level and the threshold level, like I have previously told. It should be adjusted in a way that it could be a problem. Remembering Dr. Padma Shri KAKARLA SUBBARAO garu on this day. So this is a letter given to my father when he was attended in 90s CME. And I thank you for your attention and enthusiasm. These are the workstations that I have worked on, and these are my references. Thank you.